Okay, let's do that
I
then.
think we should start because it's now nearly 10 past, and I think people I've been waiting now for a while.
Yeah, okay.
Hi, I've joined. It's Dr. Tina Boyno. Hi.
Hi, Tina. Can I, Steve, can we try now that Tina's joined? Do we have her slides?
And if we can just show my slides, it would be great. And then, yeah.
Yeah, so welcome to everybody. I don't know if anyone is, if we've actually started the thing now yet or not.
So we're all sorted.
Okay, well, ladies and gentlemen, I'm sorry about the technical problems. These things do happen. It's my great pleasure as one of the co-presenters. There's Professor Stephen Jeffrey, as you can see. My name is Peter de Jong. We're presenting from Cape Town. And Justina, or Tina, as she's known, Tina Wojno, is originally from Poland. Can you hear us, Tina?
Yes, I can. Thank you.
Dzień dobry, dobry don. Now, I'm sure we'll have to speak English because Tina and I are the only people that do understand Polish. But nevertheless, this talk will be in English, actually. STD Guidelines on Diagnosis and Treatment. Now, Tina is a microbiologist and a pathologist. She qualified at the University of Witwatersrand and the University of Cape Town. And she's going to be presenting then on the STDs Guidelines on the Diagnosis and Treatment. This talk is sponsored by Lancet. And indeed, Tina is, in fact, very high up in Lancet laboratories in the Western Cape. She heads the microbiology laboratory for Lancet. And it gives us great pleasure to be having her talk with us this afternoon. Next week, we have Professor Igno Siebert, and he's speaking on current evidence on progesterone and recurrent miscarriages. And that sponsor is Abbott. So, ladies and gentlemen, we've wasted a lot of Tina's time. I'm sorry about that, Tina. And without further waste of time, I look forward to STD Guidelines on Diagnosis and Treatment. Steve.
Yes, thanks. It is a great pleasure to have Tina. Yeah, thanks, Tina. Just from our side, it's a great pleasure to have you on board. And Tina's always available to discuss results and give us some microbiological support to our clinical practices. So we're really looking forward to this talk. So you can fire away. We can share the slides and let's get going.
Thank you so much. And once again, your apologies that I couldn't get on. We tried everything for the last half an hour, but anyway, let's get going. So I thought it would be a good idea just to remind everybody about the diagnosis and treatment and just share a couple of extra little points with you to make it simple. So just in terms of the STDs in the history, they've actually been documented for years. There's biblical texts and Chinese records of patients with spots which were thought to be secondary syphilis, as well as discharges thought to be gonorrhea. The thinking is that it arrived to the Americas by the European sailors and Christopher Columbus in the 15th and 16th century, but I'm sure it's been around for longer than that. And unfortunately, it was always thought to be associated with low hygiene and black skin waves, which we now know is not true or necessarily true. So next slide, just having a look at the CDC prevention and control and their stats. And just remember, this is just in the United States. It's extremely prevalent. And I think a lot of us forget even the cases of syphilis. So that's in 2022 of 207,000. That increased from 2018. But it's staggering. A lot of people forget that syphilis is actually still around, and it's actually not only biblical times. And if you look at chlamydia and gonorrhea, so those definitely are the top two, and we certainly see that in South Africa as well. Next slide. So the impact, we know that a lot of them can be treatable, but they do result in a lot of sequelae, which are seen by placebos and Prof. Kruger, with ectopic pregnancies and pelvic inflammatory disease. And unfortunately, herpes is not curable, and it certainly can recur, but it can be controlled. And then obviously not to mention the increased risk of transmission and acquisition of HIV and the psychosocial impact. Next slide. So when managing a case, we either look at one of two things, and you know, the state is always looked at empiric kind of syndromic management, which now we're trying to veer away from that and actually target with testing and diagnostics, obviously, to improve antimicrobial stewardship and prevent overuse of antibiotics. So once again, obviously reminding us all to treat the sexual behavior and partner management, because we see these, or partners management, because we see them coming back and again and again. Next slide. So just to let you know, during the South African, basically the NICD, National Institute for Communicable Diseases, has looked at STIs throughout the country. Their latest publication was actually in 2018. It may have changed. But what they do is sentinel surveillance is actually looking at different sites and STI clinics or primary healthcare clinics in different provinces and collating that data to give us an idea of what's actually happening in the country. Next slide. And what we were used to was this STD management guidelines in 2018. And although those still are doing their rounds, we do have a latest one which I will show you shortly, because some things have changed somewhat. And remember, this is the syndromic management approach that they have, and not necessarily the diagnostics and then treatment of the pathogens that you've got. Next slide. So the article that I'm actually referring to in the guideline, which is quite good, so and it's very relevant to the South African setting, especially now, is this one that I've got in front of you now. It's called the South African HIV Clinician Society 2022 Guideline. It was written by quite a few experts in South Africa, and it's essentially moving into best practice. And it also states, obviously, the syndromes that we're used to, so the male urethritis syndrome, the vaginal syndrome, and the genital ulcer syndrome, and it just states the most common etiologies. And you can see, actually, and from the data that I'll show you, Neisseria gonorrhea, chlamydia, as well as herpes, which is also very, very prevalent at the moment, and Treponema pallidum, which is syphilis. Next slide. So just going into male urethritis syndrome very quickly, you all know the symptoms. Don't forget the conjunctiva being infected, as well as the anal rectum with MSM patients. And also just to mention the pharynx, because we treat that slightly differently to the treatment of just urethritis. Next slide. So looking at the surveillance report that I mentioned, you can see the light blue is Neisseria gonorrhea, which takes up the majority of the cases that we see. Chlamydia trachomatis is mixed, 7%, and mixed is usually a combination of chlamydia and gonorrhea. So actually about 98% are chlamydia and gonorrhea if you take in the mixed as well. And then very little, but we are seeing an increase of it is MG in the yellow, Mycoplasma genitalium. And also just to be aware that Trichomonas vaginalis, although it is this sexually transmitted disease, we do see it's in very low prevalence in males, and that's why you'll notice that metronidazole is not actually part of the routine empiric syndromic approach initially, unless you have a partner who's got it or you're not responding to your first-line therapy. Next slide. So as I mentioned, gonorrhea, chlamydia, trichomonas, and Mycoplasma genitalium. And we'll go through, so the syndromic approach that they're recommending is azithromycin 1 gram to cover the chlamydia, and the ceftriaxone, which in the South African EDL at the moment is 250 milligrams intramuscularly. So just to be aware of the fact that it's actually would increase that dose, or it's suggested that that dose be increased to 500 milligrams intramuscularly. And the reason for this is because we are certainly seeing an increase in an emergence of more drug-resistant gonorrhea. So just overcome that resistance and prevent mutations. Next slide. So just to let you know, for those of you who've been around for long, like I have, we remember treating gonorrhea with penicillin, then we had to change to doxycycline. Then at a stage, I remember as a registrar, we were using ciprofloxacin for empirically for gonorrhea. Then we moved to cefixime, where we were giving that orally, so that's an oral cephalosporin. And unfortunately, the time has come because of the high resistance rates, and if you don't have a sensitivity empirically, ceftriaxone, and that's gone from 250 to 500. There are new drugs available. There's a new on the market. I'm not sure if it's available in South Africa at the moment, but we have done a study on it. It's called bodiflodacin, which we may actually see coming to the fore soon. Next slide. So gonorrhea treatment, as I've mentioned, ceftriaxone MICs, so the bacterial resistance is actually creeping. In South Africa, it's going up, and that's why we've recommended the 500 intramuscular for uncomplicated gonorrhea. Just to mention, as I said before, oropharyngeal is a little more tricky to treat, so it's important to actually give ceftriaxone in a 1 gram dose. If there is oropharyngeal infection. And remember, obviously, to test for that, you may not know that that's present. Next slide. Genital ulcer syndrome. Essentially, ulceration or blisters. What we're commonly seeing at the moment is a massive increase in the amount of herpes, which is often clinically obvious in terms of the blistering. You can get concomitant inguinal lymphadenopathy, which is quite tender. Syphilis can also do that, lymphadenopathy. Obviously, to watch out for the signs of secondary syphilis, which is the rash on the palms and the soles and on the body, a maculopapular rash. So we used to see buboes when chancroid hemophilus ducreyi was more prevalent. We're actually not picking these up anymore. So those are essentially lymph nodes filled with pus. So the surveillance data suggests we don't see that. So obviously, surveillance is required to see whether those come back. And one of the reasons is because we use a lot of doxycycline at a stage for gonorrhea and chlamydia, and it seems like the hemophilus ducreyi has gone away from the top of the list. Next slide.
Tina, sorry, can I just ask a question? It's Peter de Jong here. For the diagnosis of herpes, what is your preferred best practice for the diagnosis? Is it clinical inspection, or do you take genital swab? What do you do?
That's a very good question. Sometimes in HIV-positive patients and complicated immunocompromised patients, those blisters can break down, and it can look like red, ulcerated patches that look red and raw, and the blistering is usually the obvious sign, but sometimes they coalesce and it looks very it doesn't look characteristic. So in those cases, fortunately, a lot of GPs are still doing herpes serology for the herpes 1 and herpes 2. Remember, both of them can cause herpes. The problem with that is if you've got localized disease, you may not have a serological response in the blood. So, saying that it's negative doesn't necessarily mean that it is, because you can get quite a few false negatives. So the gold standard actually is either to take a swab of the lesion for PCR, or one can actually also, because you shed it quite profusely in your urine, so a non-invasive sample would be a urine for an HSV PCR.
Okay, thank you.
Yes, I'll go into that a little bit later as well. So that I'm just showing you a slide now of the herpes and the syphilis, which are the two most common causes of ulcers. And then the other causes which are not currently available or found in South Africa, we haven't detected them for a while. Although obviously the chlamydia trichomonas PCR will detect that, and one can also look microscopically for donovanosis. And we certainly can culture hemophilus ducreyi. So it's not like the labs are not looking, it's just that we're not seeing it. Next slide.
So sorry, Tina, just to get back to that last sentence you gave us, how commonly do you see the other ones when when you and I were registrars, we used to look out for that in Durban. Addington Hospital had lots of sailors having these other sort of off-piste genital ulcerations and buboes and lymphogranuloma venereum. Is that still an issue nowadays, or is it faded into the background?
Yeah, it's certainly not something that we see. I mean, I haven't grown a chancroid in the lab for years. The PCRs that we pick up the chlamydia, you know, that's a broad spectrum PCR. It doesn't actually tell you the serovirus. It doesn't tell you that it's an L1, L2, L3. So perhaps some of the ones that we are picking up are the lymphogranuloma venereum. But also, I haven't been contacted, you know, at all in the last few years with buboes. And I don't know whether that's because obviously syndromic management is better, and we are not seeing those strains anymore. But we certainly, you know, I haven't been contacted about it. We haven't detected them in the laboratory from what I can see as well.
Okay.
But yeah, yes.
Thank you.
Okay, so pleasure. And so the slide I'm showing at the moment is some photos. So the two on the left of HSV, as you can see on the bottom, that's an HSV positive patient where the blisters have actually coalesced and they popped, and that doesn't look very clinically like herpes. So, you know, that can also be a superadded infection. So remember, sometimes you can get Candida or Staph aureus infecting those lesions as well. On the top right, HSV in the female genitalia. Bottom right is Hemophilus ducreyi, which is a red, quite painful a lesion with a red base. It can have a ragged edge, and usually those are quite painful, unlike syphilitic chancres, which are usually undetected because they're not painful. Next slide. So once again, Hemophilus, just showing you the difference between Hemophilus ducreyi on the left and syphilis on the right. Remember, you can have more syphilis chancres. They can be multiple and they can be infected. And in those cases, they often look like Hemophilus ducreyi, but we're not seeing ducreyi at the moment. So more often than not, we're actually picking up syphilis on those swabs. Next slide. So just to show you the ulcer data and surveillance. So as you can see, out of the ulceration, patients who've had ulcers, 55% of those turn out to be herpes simplex, which is quite significant. 9% are treponema pallidum, and then in 35% of cases, we actually don't detect anything. So that could either be trauma-related or other bacterial infections. Mixed is 1%, that's a mixed treponema and herpes simplex. And then as you see, the three others that I mentioned are not, have not been detected by surveillance. So we obviously need a new surveillance report to see if that's the same this year and last year. Next slide. So genital ulcer syndrome, we know that for the first episode we treat for 10 days with acyclovir, and our first line go-to for syphilis is always benzoyl penicillin, which is an intramuscular dose. You know, often, you know, we don't pick up the syphilis clinically because we don't see the chancres. So often it's picked up in a secondary or latent phase, in which case obviously we need to remember to give 3 doses if it is latent. And then recurrent episodes we treat for 5 days. Next slide.
Tina, just to go now, just to get back to just before warts, just to get back to syphilis, what do you suggest? We usually pick it up. Speaking for myself, I usually pick up syphilis in pregnant women when you do the serology. What do you suggest is the best treatment for syphilis in pregnancy?
So we still actually say penicillin. You know, penicillin crosses the barrier, and so penicillin.
The placenta.
So penicillin is definitely the way to go. Unfortunately, obviously you can't use doxycycline, so we always do recommend penicillin. The other alternative occasionally with severe penicillin allergies is to do desensitization, and we often get the immunologist involved. Alternatively, one can also use ceftriaxone, but that's obviously a more prolonged course, so we normally use a 10 to 14-day course. But we always say first line, best for baby, best for mom would be penicillin.
Is that benzyl penicillin, the intramuscular stuffy stuff, the white stuff? Benzyl penicillin. Yes. And what dose?
So we're giving the 2.4 million units. If the patient is well and has no stigmata of syphilis, then we need to assume that they're latent. And for latent, I always say we don't know if it's early or late latent, so we must assume that it's late latent, which means they've been infected 2 years ago, 1 to 2 years or more. And in those cases, it's 3 doses 1 week apart.
Okay, 3 doses 1 week apart, 3 doses. And that's the very painful one, is it?
It unfortunately is. So the recommendation is actually to mix it with lidocaine in the same injection needle. Yeah.
Yeah, I remember I got a shot of that, and it was exceptionally painful.
Yeah,
I was a medical student, and I got exposed by accident. I must say, it hastened to add it. It's not primary caused by.
I got exposed, but it's okay. Move on.
Okay. Right.
Yeah. You know that it's painful. Yeah. So always to mix with the lidocaine. Yeah.
Right. Thank you.
Okay.
Another question. Yeah. Sorry, if you finished that, it's is it still important to differentiate HSV into 1 or 2 since the management is the same, and we know that because of oral sex there can be transmission of herpes labialis genitalia. Do you differentiate between the 2 or not really?
Sorry, say that again. Do we differentiate between the 2?
The question is it important to differentiate herpes and virus into 1 or 2 since the management is the same?
No, it's not important. You know, as the speaker has said, you know, you can certainly get cold sores with oral sex that are transmitted to the genital area. It is less common, but we certainly are seeing HSV1 in the genital tract as well, and the management is exactly the same. Yeah, usually we have more severe disease with 1, but with 2, HSV2, but certainly HSV1 can also cause a disease.
Thank you.
Pleasure. Okay, genital warts. So just my main point on human papillomavirus is that it's extremely common. So, you know, the prevalence study says you've had if you're a sexually active person, about 80 to 100% of us have actually had HPV at least once in our lifetime. And a lot of us don't even know about it because our immune system will clear it. We don't get the warts, we don't get the cancer. But obviously the high-risk strains are important for, you know, that's why we screen so often with for pap smears to make sure that we are not causing any cancer. And so we do also see an increased prevalence in HIV patients. And yeah, it's important to, I just say, important to screen. Next slide. So just to show you in terms of prevalence, they looked at a couple of sentinel sites once again, just to see, you know, they took a couple of young women who attended these sites, and they just screened them for HPV. And you know, in the overall HPV prevalence was up to 70% in these women. So whether they were symptomatic, not symptomatic, whether they had you know, any features, but just to make you aware that, you know, it is extremely common. And just to remind you that, you know, pap smears are essential. Next slide. So obviously one can also get genital warts. And what's important as well is, you know, especially with males who have sex with males and doing anal screening, which is not currently done routinely, it is done overseas. So we have had quite a few requests in the Cape Town region, you know, to swab to see whether the genotypes are there. But once again, if you've got no lesions, we can pick them up, and it doesn't necessarily mean that you will develop any lesions. You know, it may have been recent exposure, but it can detect the high risk as well. Next slide. Okay, so moving on to vaginal discharge syndrome. You're all aware of the symptoms, itching, painful maturation. A lot of the time it's actually mistaken for urinary tract infection. So often we get a urine sample and we grow a candida, and in 99% of those times it's actually the candida that's coming from the perineum or the vagina that's causing the urethritis. And then when we treat the local candidiasis, the urinary symptoms settle. Next slide. So just to give you an idea of vaginal discharge syndrome, which is a little bit different to the males, because in females it's not all sexually transmitted. And I think a lot of people forget this. So candida and CV, bacterial vaginosis, which is the Gardner ring vaginalis and all the other bugs that sit on the epithelial cells, makes up about 40% of it. And then we pick up chlamydia and Neisseria about 34% of the time. And then an increased amount of Trichomonas vaginalis as well compared to the males. Next slide. So obviously we need to remember physiological discharges as well, foreign bodies, allergies, etc. And I have mentioned the complications, especially the infertility and ectopic pregnancy, and then also preterm delivery. Next slide. So Trichomonas vaginalis, we always look and see if we can figure it out clinically, but it's not always possible. Trichomonas causes a frothy white discharge that's not odorous. Bacterial vaginosis is normally a fishy odor. Candidiasis is quite obvious with its white, patchy, itchy discharge. And gonorrhea normally causes a very, very inflamed, red looking cervix and vagina and vulva. This can happen with chlamydia, less commonly, but it certainly can happen with chlamydia as well. Next slide. So in terms of syndromic approach, as I've mentioned, we use azithromycin plus the ceftriaxone, and then we use metronidazole for the Trichomonas vaginalis, which is a lot more common in the females, and that's why we don't see that in the MUS treatment guidelines. Mycoplasma genitalium normally is only treated once the patient is not getting better initially. Then one can either consider, obviously you can look for the bacterial vaginosis and the candidiasis, but mycoplasma genitalium can also, we can pick up on PCR, and that is a little bit of more of a complex treatment guide, and we have seen quite a bit of resistance, but I will discuss that a little bit later. Next slide. So etiology of vulvar vaginitis, you can see, can be hyperestrogenism. So yeah, we've often, not able to detect anything. It's often a postmenopausal woman, and we find that actually the white blood cells and the red blood cells on the vaginal empty nest is actually associated with, probably due to low estrogen. And then obviously pessaries, foreign bodies. We've had patients where they've got a discharge and then we find that there's a tampon that hasn't been taken out. I'm sure you've seen everything, but not to forget, psoriasis, atopic dermatitis, especially if you're getting negative infectious results. Next slide. So let's focus on testing for the next few minutes. Next slide. So just in terms of screening frequency, so the HIV Society obviously has some groups where we recommend more regular screenings. For commercial sex workers, we recommend 3 to 6 monthly. Anyone at increased risk of HIV, men who have sex with men, PrEP users, also annual screenings. And for pregnant women, we also add the Trichomonas vaginalis. And then transgender and gender diverse is also at least annually, and they're based on your risk assessment. Next slide. So whenever we do testing for STDs, one must also consider HIV and hepatitis B. Hepatitis B is extremely infectious. It's about 100 times more infectious than HIV. So just to remember those two things, and obviously syphilis serology as well. So those are all on blood, on a clotted tube. And then essentially looking at the two types of presentations. If somebody's got a discharge or a urethritis, one can do vaginal MCNS for females, especially to exclude the BV and the Candida. One can do testing for just chlamydia and gonorrhea PCR, which we know is the most common cause for the urethritis and infectious cause of discharge. There are numerous STD panels, urethritis panels, and those will include combinations of mycoplasma, ureaplasma, trichomonas vaginalis. It is a lot more sensitive to pick up trichomonas on a PCR than just looking under a microscope for the little bugs, because they can actually die as they get to the lab and they look like live cells. And then for ulceration, the two things that we request or recommend testing is herpes 1 and 2 PCR, and then serology. One can consider doing, obviously in consultation with the microbiologist, we can then look for other things like Haemophilus ducreyi or other funnies if the patient is not getting better. So that can also always be discussed with the microbiologist. Next slide. In terms of the samples, just remember, if you are culturing something and you want an MCNS for culture of either the vagina or the urethra or the vulva or the cervix, always use a gel swab, because the gel is what keeps the bugs alive in order to get into the lab quickly. Gel does not work for PCR because it clogs up the PCRs. So whenever asking for PCRs, it's better to either do a urine sample or do a genital swab. And the swabs refer to either the PCR swabs that are in a liquid format, that will always say molecular testing, or a dry swab. Remember, it can be dry because we're not culturing it, and the dry swabs will not interfere with the PCR. And then obviously for serology, clotted blood. Next slide. So just to show you the samples, in TNS, the gel swab, we can look for trichomonas, we look for those clue cells, we give a BV score. Candida grows really well. There's different strains of Candida respond to different things. So sometimes the glabratas are very difficult to treat. So involve a microbiologist and we can advise you on what to use. And gonorrhea we can pick up quite easily. Remember, chlamydia doesn't grow in an MCNS, so you have to do a PCR. Next slide. So for PCR, either urine or a genital swab. Next slide. So the swabs are the dry swabs or the molecular fluid swabs. And then you'll get a report of all the STD bugs, including the mycoplasmas, the ureaplasmas. Next slide. And then serology. Next slide. Just a picture of the clotted blood. Just don't forget those three, which need to be tested as well. And then my last slide, just to remind everybody about ureaplasma and plasma. They are often considered just basically coincidental. Not everybody who's got a ureaplasma and mycoplasma necessarily has an infection or disease. They don't always need to be treated. Often if I pick up a Candida and a ureaplasma, I say treat the Candida first. If the symptoms settle, we don't need to treat further. Obviously, in a patient who is being worked up for infertility, it's one of the things that should be treated, because it can cause, chorioamnionitis, preterm labor. We can then also advise on empiric treatment strategies, but often doxycycline works for ureaplasmas as well as homonas. And then if we do pick up genitalium, which is usually pathogenic, the NICD actually does perform molecular sensitivity testing, and we usually treat empirically first, and then if there's resistance detected, we use pristinamycin. So I've been involved in a couple of cases where somebody's just not getting better, and we've had to do this, but it's a handful of patients. But obviously we are here to advise if required. And that was my last slide. So thank you for your attention, and I'm happy to take questions.
Okay, Tina, thank you very much indeed. Firstly, I'd like to apologize the fact that your slides were shown by Wendy, and you were not actually, you were speaking through a telephone, as we can see. So your audio quality, some people did find the audio quality less than optimal, and the slides were flickering. for which I'd like to apologize on behalf of the of you. You know, it was suboptimal. We do have one or two other questions. Steve, can you just start off with the questions, please?
Yeah. So the first question is, how do you then follow up a male with high-risk HPV infection? In women, we would usually do a colposcopy, provided they have high-grade SIL or persistent LG-SIL. But what about male follow-up? What are your suggestions there?
So, you know, usually we say because males obviously have intact skin, so the likelihood that one will get any localized disease is quite small. You know, usually what we do, you know, just even doing scrotal and penile swabs, even if we detect the organism, it doesn't necessarily mean that the male will necessarily get an infection or cancer or warts. So usually there isn't actually a perfect follow-up for this. We will follow up clinically and advise if any lesions do pop up, then they can present. A lot of them are still quite anxious, unfortunately, so they usually want to know whether they are, you know, whether they are infected, and all we can really tell them is whether there is the DNA is present on the urethra and on the penile area and the scrotum. But once again, that doesn't tell us anything. It doesn't necessarily translate. So there are no guidelines on following these up other than clinically.
Okay, thanks. Yeah, so I was also wanting to know this, in case of vaginal discharge syndrome, where does metronidazole gel fit in? A lot of people do use metro gel, maybe easier for the patients, their side effects. But do you think it's got a role in management of a vaginal discharge?
Thank you for bringing that up. Yeah, so there's certainly been studies with metronidazole as well as oral metronidazole, and one would think that the local metronidazole, because it's given locally, would work. Unfortunately, we do see failures. So the recommendation is to usually go for the oral, because we seem to get higher levels in the vagina rather than giving it locally, which is completely against you know, common sense. But, you know, I certainly, in some cases, I have been called and, you know, the patient really doesn't want to take it orally, or they've taken it before when they're feeling ill. So it's definitely worth a try. But obviously to warn your patient that there might be a relapse, in which case they'll need to come back and get the metronidazole. And also just to mention, certainly the longer duration metronidazole versus the stat dose is preferable from a decreased recurrence point of view.
Thank you. Tina, talking about dose, what dose do you recommend for oral flagyl?
Oral metronidazole dose, so the tablet that we've got in the country is a 400 milligrams. So what we do is we recommend that to be given twice a day, so BD, and we give it for 7 days.
I'll tell you why I asked that question. Somebody said for the last several years, 200 milligram tablets have been available on a TDS dosage regimen. Are you in favor of that because it makes less nausea?
No, I think we do need the 400 milligrams. So if that's basically 200 milligram tablets twice a day is preferable.
Okay, thank you for that. Here's another question. It's a good one. It's about STD screening. That's the blood screening. Which one yields better results, urine or serology sample? And if you can answer that. Then the second part of that question is, if you do a blood panel for STIs, which do you think you should screen for?
Okay. So the first question with the serology versus urine. So once again, we've had cases where doctors are asking for, let's say, chlamydia serology, and we do get a lot of false negative results. We also get funny false positive IgMs that don't seroconvert to an IgG. So I find chlamydia and herpes serology not useful at all, and I definitely wouldn't recommend it. It's not standard diagnostic practice. So definitely more, you know, to look for the actual organism by doing a PCR either on the urine or on a genital swab. So I hope that answers that question. And
Yeah.
then secondly, sorry, what was the second question?
The second question was, if you're going to do an STD screen on blood, and the serology, which organisms are best sought for and which are a waste of time?
Okay, so definitely, obviously HIV, hepatitis B, and syphilis, those are gold standard.
Gold standard.
None of the others. I wouldn't do gonococcal antibodies. I wouldn't do chlamydia antibodies. I wouldn't do any other antibodies, herpes antibodies. All of those are a waste of money and a waste of time because you don't
Got it.
enough on. Yeah.
Got it. So just to recap, you said if a woman wants to check for chlamydia, which is a very common question, what did you say? Did you say PCR on the urine or a PCR on a vagina?
Yeah. So either or. So what we do at Lancet as well, just to make it easier, is if there's been an LBC sent for cytology, so any LBCs, we can perform the chlamydia. So we've got a combined chlamydia, gonorrhea, PCR. So that can be requested on an LBC, so you don't need to take another sample. So we often have after requests to do that on an LBC. Alternatively, if they want to be screened, one can do it on a urine. That's obviously preferable for the infertility patients. And even if there's a biopsy, sometimes I know the fertility clinic send us biopsies of the endometrium. One can also do chlamydia testing on that as well.
Right.
A PCR.
Okay. Thanks very much indeed. Steve, do you have any more questions coming up?
Well, I mean, I think this is also a very nice question here from Kathy van der Westhuizen asking, of a patient struggling with vaginal discharge, she tested positive on PCR for Meta-Mycoplasma hominis and Ureaplasma parvin. And Kathy would like some advice on the treatment, please. She is well and immunocompetent, but has unprotected sex in serially rather short lasting monogamous relationships. So it's really just that patient where you've got this vaginal discharge and you're just not really getting on top of it. And what do you think of that? And how do we approach that?
Yeah, thank you. That's a very good question. So in a patient who comes in and they've had a sexual encounter and they're asymptomatic, I probably wouldn't treat it, and I would leave the Ureaplasma parvin and I'd leave the Mycoplasma hominis. But in a patient who's had a change in their discharge, one can certainly then treat, and it's not necessarily an STD. A lot of people will think that that's how it was picked up. It's not necessarily that. It can be just a change in the vaginal flora where those organisms have now overgrown the others. So in those cases, and for those two organisms, I would probably use doxycycline, 100 milligrams twice a day for 10 days. To see if the discharge actually settles, because in some cases you can get discharges with these if they overgrow.
Okay.
Thank you. Here's a question, Tina. One of our problems for treating is, Lionel suggests that bicillin is unavailable in private practice. How long should we treat with doxycycline orally? That's for syphilis.
Yeah. So thank you for that question. It's also a very important question. I have actually been told by a lot of doctors that it's unavailable. So it actually, so that's true. However, what they've done is they've put penicillin, the benzyl penicillin, on a Section 21. So one can still actually get that. So any hospital pharmacy can get that for you with a Section 21 form. And unfortunately, that made it a little bit more difficult for us to get, but that's certainly something that I would try as a first line. If you definitely cannot get a hold of it, which most of the time if you go via Section 21 you can, the treatment would then be the doxycycline, 100 milligrams twice a day, and then we use that for 14 days, so for 2 weeks.
Okay.
Hospital, they still have it available, bicillin.
Yeah.
And sometimes benzyl penicillin is available from our pharmacy. I don't know if they schmuckle it from somewhere, but it is available. So you've got to be lucky. Fortunately, you don't see it very often, but when you do need it, you really do need it.
Yeah.
Yeah.
Tina, can
Yeah,
I just ask you
absolutely.
can I just ask you one last question? And thanks again. It's been a wonderful talk. About just your first line for Candida. A lot of people are using Fluzol, Canesten. You know, it seems to be people seem to be chopping and changing. What are your thoughts on that? I mean, where should we go without, you know, see a patient with a standard Candida discharge?
That is a fantastic, very, very relevant question, because Candida is extremely common and it's sometimes difficult to treat, especially the recurrence. Also, just to be aware that I definitely find that the topical treatments work better and help with recurrence. I know a lot of people just want to take a Fluzol and get it over and done with. I do, however, find that the topical with the local administration seems to work better. So I've always been in favor of topical treatments. For first line, so basically somebody's presenting that hasn't had it before, I normally advise twice a day for 7 days. Any recurrent Candida, I would recommend at least 2 weeks every night. What we do is, you know, any recurrence, I think definitely should be speciated by the laboratory. So what I actually do is I give you a species at Lancet, because we get a lot of gynecological samples here. So we've decided that we're going to speciate them all to see, are they crudii, are they glabrata. The glabratas are often the ones we pick up for the recurrent candidiasis. And these are the ones that often don't respond at all to your oral fluconazole, that don't respond to the topical fluconazole. So the one thing that we try and use is nystatin, because they're very sensitive to nystatin. The problem is the pharmacies are no longer stocking the intravaginal nystatin. So often they use the topical one, which is the one for the vulva. If there is intravaginal Candida glabrata, then what I normally recommend is trying intravaginal probiotics, live probiotics, just to decrease the pH, and that usually overcomes the overgrowth of the Candida. So I'm happy for anybody to contact me and I can give you a dosage regimen for that, because it works extremely well. I sometimes use it for other recurrent vaginitis as well. The other thing that I've also been trying, which has just come onto the market, I'm sure the reps have visited you, is something called fluomycin, which is a vaginal antiseptic that you use Noctave for 6 nights. That also seems to help. I've actually tested it in the laboratory and it seems to kill the Candida. So once again, any of these difficult ones, I've got a long, it's a separate talk on itself, Candida, vulvar vaginitis and recurrent Candida. So I could go on for hours. But if anybody has a case like this, please give me a call. You know, I can share my cell phone number with you. You're welcome to WhatsApp me or text me, and I can give you some advice and assistance. It can be quite difficult to get rid of.
Well, thanks, Tina. I mean, that's wonderful. We look forward to hearing that talk, because I mean, I think we all do tend to struggle with those patients, and it would be wonderful to get a more robust approach. Sorry, Peter.
Yeah, I can certainly do that. Absolutely. So for those of you, I don't know if you're happy for me to share my cell phone number if anybody needs to contact me.
Share number.
082 575 5115. So it's 082 575 5115, and you can WhatsApp me and just give me a history, and then I can tell me what the patient's been on, and I'll give you advice in terms of what to use. I've got my little secret remedies.
Secret Lancet remedy. One last question, just before we let you go. One of the anonymous has just written in to say that for a woman with recurrent vaginitis that seems to be resistant to everything that they've ever tried, I'm sure anybody that's a gynecologist has met women and patients that seem to be impossible to treat, and whatever you throw at them, it doesn't seem to treat the vaginitis. What swabs would you recommend, And are anal swabs useful, or just vaginal swabs, and what sort of swab is required for this?
Thank you for that question. Yeah, so I can help you with those as well.
Okay.
Yeah, so what we would ideally recommend is a gel swab, so the blue one with the jelly at the bottom.
Right.
And then on the form, you just write Candida recurrence, attention Dr. Tina, and then I will speciate this for you and tell you what species it is, and then we can take it from there. And we can give you a 6-month plan of what to do. What I normally do is I decrease load first with antiseptics and douches. Then we repopulate the vagina with probiotics intravaginally, and it works like a bomb. So let me know. Give me a call and I'll help you. Yeah.
Okay, thank you very much, Tina. Last word, and thanks to Steve. Would you like to thank Steve? And just before he does his final thanks, Tina, I'd like to, on behalf of our team here, apologize for all the technical problems we've had. It's been, I know that we've been trying for 35 minutes prior to the talk to get everything sorted out, and yet we still had these enormous technical difficulties. We have had apologies then from our technical staff. I'd like to thank the technical staff. And then Steve, next week we've got Professor Efno Siebert. But for now, would you like to thank our speaker, please?
Yeah, absolutely. I mean, it's been wonderful. Thanks so much. I think you've, given us lots of answers, but again, I think we'd really like to engage with you further on that other talk on Candida. I think that's, that'll be very useful to us. And I think you've maybe shown us what we're doing incorrectly, how we're approaching these patients. We maybe need to be a little bit more thorough and maybe make more use of the lab. And so I suppose thanks very much. And despite the technical issues, I think it's been wonderful. It hasn't really detracted from the message and what we've been able to achieve. So thanks so much, and thanks for sticking with it and for making a plan despite the technical problems. And so thanks so much, and thanks of course to Pete for keeping these webinars going and for driving along so nicely. And again, also to the team.
Nadir and Wendy.
Thanks so much. All right, but I think that's
Good
it.
night, everybody.
Thanks so much. Thank you.
Thank you. And I will, I'm happy to share my presentation, and you're welcome to send it to all the members as well. So I'll send it to Wendy.
Thanks so much.
Okay. Thank you so much.
Thank you.
Good night to everybody.
Bye-bye.
And God bless you. And we would see you, God willing, in a year, in a week from now, same time, same place with Professor Siebert. Thank you. Good night.
Thank you.
Thank you.